So Efrat and I are going to present a little bit today about All for Them. We wanted to share some information about we're going to give you a little bit of background around the HPV vaccine and the challenges, and a little bit about our program, and then we'll talk a little bit about best practices from what we've learned in the work that we've done. Next slide. So I wanted to begin with some background regarding the current state of HPV vaccination and some of the challenges that are related to HPV vaccine uptake. So the Advisory Committee on Immunization Practices recommends that all age-appropriate vaccines be given in the same visit. But according to the 2022 National Immunization Survey Teen, while US rates among 13 to 17-year-olds for Tdap and meningococcal vaccines are almost 89.9 and 88.6% respectively, the HPV vaccine rate for girls is 64.6 and for boys is 60.6%, with an overall rate of 62.6%. And Texas rates are slightly lower than US rates, with the largest difference being HPV vaccination in boys. Next slide. When we look at rates over time, rates for both Tdap and meningococcal vaccines have consistently been over 80%. In contrast, the HPV vaccination rates, while steadily climbing, remain well below the Healthy People 2030 goal of 80% completion. Next slide. In 2022, the US Teen Survey found no substantial increase in HPV vaccine rates for the overall sample. Coverage with at least one dose among Medicaid beneficiaries declined by 3.3 percentage points compared with coverage in 2021, which is the first time that's happened, while coverage was stable among those with private insurance. So you can see in this graph that both privately insured and Medicaid groups had similar coverage in 2022, and uninsured adolescents continued to have the lowest coverage with at least one dose of the vaccine. As you may know, the World Health Organization recently named vaccine hesitancy as one of the top 10 threats to global health. HPV vaccine hesitancy and refusal rates are on the rise. Sanawani and her colleagues found that from 2015 to 2018, while HPV vaccine safety reports in the Vaccine Adverse Events Reporting System had dropped significantly, rates of HPV vaccine series refusals, as reported in the NIS Teen for the same time period, increased significantly, primarily for safety concerns. Not surprisingly, HPV vaccine hesitancy increased during the COVID-19 pandemic. And in a survey of healthcare professionals in Texas, 17% reported increased hesitancy, while almost 15% reported increased refusal, and over 19% reported that they saw a decrease in HPV vaccine uptake. In a recent survey of US parents, those who identified as vaccine hesitancy were substantially more likely to have refused or delayed a routine child vaccine or a flu vaccine in comparison to parents who were not vaccine hesitant. We also continue to see increases in the numbers of students who are filing for vaccine exemptions. While these rates have been rising steadily in the last decade plus, you can see that there's a sharper rise since the 2020-2021 school year. Next slide. Exemption rates are substantially higher for youth in private schools, but you can also see here that even exemptions in public school youth, which held relatively steady at about 1%, started climbing dramatically in 2018 to 2019. Next slide. So there are multiple factors that can impact increases in vaccine hesitancy and reductions in vaccine uptake. In a 2017 systematic review of general vaccine uptake, Smith and colleagues documented individual, social, and contextual factors that are associated with not vaccinating a child, such as perceptions of adverse effects from vaccines, including beliefs that the vaccine is unsafe, causes of side effects, and that they're more dangerous than the illness. Also, not receiving a recommendation from a vaccine provider, or preference for natural immunity, and also appraisal of the illness, including low perceived susceptibility to the illness, low perceived risk of infection, and low perceived severity of illness. Also, low or no trust in the healthcare profession, which has been growing. And those are just a few of the factors that they found. So it's important that we understand the factors that are associated with vaccine decision-making to enable us to design more effective interventions. Next slide. So typically, the most effective health promotion interventions include multiple strategies across multiple levels with integrated actions to support each strategy. So today, we're going to share with you the All for Them program, which is a multi-level, multi-component strategy that our team has developed and honed over the past 7+ years, specifically to improve uptake of HPV vaccination and increase parental acceptance of this cancer-preventing vaccine. All for Them is funded by the Cancer Prevention and Research Institute of Texas and includes 3 evidence-based strategies, each of which has multiple elements. The first is a social marketing campaign for parents, youth, and community members. We also implement a comprehensive school-based vaccination clinic, events that are hosted either in schools or in communities as a safety net offering for families that cannot bring their children to a health clinic for whatever reason. And then there's training for school nurses, which includes continuing education on HPV vaccination, communicating with parents, and the importance of entering all vaccines into the district vaccination database. So to develop our social marketing campaign, we worked with a cause-based marketing firm. And the design process involved multiple phases, including understanding the current vaccine landscape for HPV. Our discovery process involved active inquiry of key roles, content experts, and priority populations to accurately frame the population of focus and goals for the campaign. We also interviewed every team member to share their perspective on the goals and visions of the project. And we conducted an extensive review of the literature and explored existing campaigns as well. We knew that our messaging needed to set us apart from all the other messages out there around HPV vaccination. We had to change the HPV vaccination conversation from one that starts by focusing on addressing stigma and misconceptions associated with HPV to one that empathizes with parents and empowers them to make the best decisions for their families. We wanted to build a conversation around HPV that conveys urgency for parents to get their child vaccinated and presents the HPV vaccine as an important tool that represents the best care you can give your child right now. The bilingual campaign promotes empathy and empowerment coupled with education. We framed our message in the following way. We empathize with parents. We promote the HPV vaccine as cancer prevention. We avoid the introduction of barriers, such as talking about HPV as an STI, although we address barriers with an individual if they bring it up. We don't single out HPV vaccine, but rather present all adolescent vaccines together in a bundle, hence the program name, which is All for Them. We emphasize that everyone needs the vaccine, and then we reinforce that earlier vaccination is better. The message we're sending to parents with both the campaign language and the imagery is that you wouldn't give your kid half of what they need, so get them all their vaccines. Next slide. So campaign materials include printed items, such as the consent packets we send home to all parents. This packet includes a cover letter that's signed by the school district and an HPV vaccine fact sheet, along with provider consent forms. Our electronic campaign materials include our website, social media posts, and paid ads on Facebook, Twitter, and Instagram, as well as digital radio ads and school-based messaging. The second strategy is the comprehensive school-based vaccination clinics that are conducted in participating schools in collaboration with our vaccination partners. The clinics are comprehensive in that children are provided with any vaccines that they need at the time. We offer 2 types of events: pre-consented clinics that require parents to provide a consent form indicating the vaccines that they consent their child to receive, and community events, usually during holiday breaks or on in-service days, when children are out of school. So both types of events are needed in the communities we serve, as we know one size doesn't fit all. On the one hand, the community events require a parent to be present, but they allow families to bring all their children who need any vaccines to one event. And since they happen when kids are out of school, a parent is more likely to be available to bring them to these events. On the other hand, the pre-consented clinics at the school allow children to get all the vaccines that they need during the school day without their parent having to be present. But they're only conducted in selected schools. The pre-consented clinics act as safety net provision for parents who cannot, for whatever reason, get their child to a healthcare provider to receive the vaccines that they need. And parents trust the schools, so they're more likely to be comfortable with their child receiving vaccines at the school. We know only a small percentage of parents will take advantage of the pre-consented clinics, but for those parents, it can mean the difference between getting their child vaccinated or not. When we coordinate a clinic event with a school, we want to make it as easy as possible for them to host the event. So we provide them with tailored communication scripts for conducting parent outreach and encourage them to promote the event in as many ways as possible to maximize the reach of their message. Our team also engages with parents through activities at the school like student pickup and drop off, parent events, and with personal phone calls to parents who have children that need vaccinations. We spend a lot of time talking with parents and providing education, answering questions, and helping them complete the consent materials for their child to participate in a vaccination event. Our approach is community-based, using schools as an alternative setting for vaccination. And we're currently implementing All for Them in 4 school districts in Texas. 3 of those are in the Houston-Harris County area, and one's in the Fort Worth-Tarrant County area. We work with as many as 5 different provider partners across those districts as well. Next slide. Our final strategy is nursing continuing education. School nurses often lack an understanding of the importance of the HPV vaccine. Most of the vaccines that they're familiar with prevent illnesses that have tangible symptoms and could affect students during any given school year. So school nurses have likely dealt with outbreaks of those communicable diseases. However, they won't experience a student having an HPV-related cancer. So we give them information, including didactic learning about HPV vaccine and why it's important, the critical role the school nurse plays in recommending HPV vaccination for their students, how to become an HPV vaccination champion, guidance and skills practice on effective strategies for communicating with parents about HPV vaccination. We also reinforce the skills for entry of HPV and other recommended vaccines into the district immunization records. To keep nurses engaged, we included HPV-related cancer survivor and nurse testimonials throughout the course, which provides insight on how other school nurses talk with families about HPV vaccination, as well as the impact of HPV-related cancers on individuals and their families. These testimonials are particularly important for reinforcing the relevance of the vaccine for their middle school students to prevent cancers that might happen several decades from now. The course is open to all school nurses, so the vaccine can be given as early as age 9, and school nurses often move between schools, including shifting from elementary to middle or high school. So the course is recommended for school nurses in all grades. Next slide. So Efrat's going to take over from here.
Thank you so much. So we're really excited to be able to share sort of some selected results from the project to date. I can advance my own slides. That will be helpful. I need somebody to advance the slides for me. So we want to give you all a sense of the numbers of youth served by our project. And so to date, we've conducted over 320 vaccination clinics. And so again, that's just one piece of the overall project and approach. But in those clinics, we have been able to vaccinate over 8,300 children and adolescents, which has been really exciting, of course, in partnership with our healthcare providers who actually do the shots in arms. And of those youths who have been vaccinated and participated in our clinics, 5,341, we'll count that extra one, always important, HPV vaccines have been administered. And so when we look at those 5,300 plus vaccines, we are seeing that about a third, excuse me, 2/3 of the students vaccinated are receiving their first dose in the series. A very small percentage, about 1%, who are on a 3-dose schedule based on the age that they are at the time and when they got their first dose, are receiving an interim dose, so sort of a second dose out of the third dose in the series. And 1/3 of the doses administered are vaccine completion doses. And we are seeing those completion doses. In particular in the high schools where we're implementing, we do a lot more completion doses. And in the middle schools, especially among the 6th and 7th graders, we're starting their series for them. And in many cases, actually being able to complete the series. We didn't have the data to present today, but we have probably well over 100 to 200 students that we've been able to do their complete series, both doses 1, 2, and in some cases even 3 doses across the project year, since we're implementing across many academic years. And a lot of times the students are still in the same schools year after year. And so if you can see in the bottom section that's sort of dotted off, we collect individual level data on a select group of students whose parents give us permission to do so. And so from those data, so you'll see that the numbers look a little bit different. From those data, we can see that by far we are providing many more HPV vaccines than even the other adolescent vaccines that are typically given at that age, even though we're offering all of the vaccines. And I think that that goes back to what Dr. Cuccaro talked about earlier, right? So many students are coming to us at these clinics having already got their Tdap and meningococcal vaccines. And we know that there is sort of a backup and that gap in those that still need their HPV vaccine. And so this project is able to help close that gap for those students. And I will say that and these are data across since the beginning of the project. And when we looked at the impact of the clinics in the first few years of the grant, the original grant where we were just working in one school district, HPV was still number 2 to influenza. And now we're seeing many more students getting HPV vaccine even compared to influenza. And so that's been an interesting shift. And then you can see all other vaccines are combined at the bottom. So hepatitis, varicella, MMR, etc. And one of sort of the hallmarks of this project and of our approach is high endorsement of the HPV vaccine among parents of the youth participating in our clinics. So of those who received any vaccine at our clinics and needed an HPV vaccine, 96% of parents consented for their child to receive the vaccine. And this high rate has been relatively stable over the course of the 7 years in which we've been conducting all for them, even through the pandemic and even through, the increased vaccine hesitancy that providers even are seeing during those first few pandemic years. So we also, Dr. Cuccaro talked, just a few minutes ago about the nurse education that we're providing to school nurses. And so we assessed the nurses who took the online continuing education course. And this has been implemented in recent years statewide. So not only in the districts that we're partnering with for the implementation, but offering this to nurses across the entire state of Texas. And in some cases, we've had nurses from other states find out about our course and take it as well. But of the 72 nurses who completed both the pre and post surveys, we looked at their knowledge, attitudes, and practices related to HPV vaccination, and we'll share some of those results here with you today. So at each time point, we asked nurses about whether they perceived certain challenges, such as lack of knowledge, concerns about vaccine safety or efficacy to be a major barrier, or somewhat a barrier, or not a barrier to them in making a recommendation for HPV vaccination. And we saw significant improvements both in the level of knowledge about HPV and in the understanding of the recommended dosing schedules, becoming less and less of a barrier for those nurses after participating in our education. And we also found that the nurses' confidence to engage with parents increased. So 6 out of our 7 items on self-efficacy variables that we assessed significantly improved. And in the largest increase, 53.8% of the nurses, which was up from just a little over 22%, indicated that they strongly agreed they could explain the benefits of HPV vaccination to parents. And so this has been a really exciting factor for us to see and continues to motivate us in improving the nursing education experience for nurses in future years as well. So, we'd like to talk with you all today about some of the lessons that we've learned in the past 7 years or so of doing this. And so, implementing our parent, and in some cases, we've actually shifted to a student focus for the high schools as well. So, in implementing our social marketing campaign and the mobile vaccination program in public middle and high schools, has really brought the opportunity to, it's given us the opportunity to improve the health of thousands of students, right, who might otherwise have little or no access to critical immunizations. But because we have been working with multiple school districts over the years, Dr. Cuccaro mentioned we're currently implementing in 4, but we have implemented in as many as 6 school districts at any given time. Each of them has their own unique needs and processes, and we're working with multiple providers. They have their own needs and processes. And so this initiative is really has come with some challenges and opportunities to learn from what those unique positions bring, and how we can continue to implement our program with fidelity while also accounting for the incredible flexibility needed in implementation. And that's really sort of want you all to keep that flexibility idea in mind as we talk through the next few slides, because that has really been the overarching theme here for us as we've started to recognize, especially in the sort of pandemic and post-pandemic years. Everything changed in 2020 for all of us doing work in the immunization and public health space. And so we've really, what has worked for one district, we have learned doesn't necessarily work for other districts, given their size, the student population, the provider needs, the culture. Um, and so I feel like this is an episode of Law and Order. These are our stories, right? From what we have learned. And so the first thing that I would like to talk about is the need to have a strong champion. And I think for anyone who has worked in public health, this probably will not come as a big surprise. So partnering with a really strong champion for immunizations, and this is often at a district level, somebody who really deeply believes in our mission, that increased the likelihood of our success, both within the district and at the campus level. And so when you have leadership at the district level, right, this can be like the director of health and medical services. In some cases, the superintendent has been involved and been supported. That can really ensure direct access to the principals and other leaders at the campus level. And in turn, those campuses are more likely to support All for Them and our initiatives and stay engaged when there's someone who's really championing this at the sort of highest levels of involvement. Working in public schools comes also with the challenge of a lot of turnover. So principals change, assistant principals. We work really closely with other coordinators who may switch from school to school. Nurses come and go. And so having those staff turnovers and sort of rotating from year to year, that district level champion has really been the continuity that the project needed to allow the schools to continue implementing with confidence, right? So if we have a new principal next year, they may not have heard about this or know about All for Them, even though we've been implementing for 5 years. But having that champion at the district level provides the continuity that we needed across years. And each district also has its own needs for a champion. So we have found that the more centralized the school district was, the more effective that the champion at the district level can be. But then in decentralized districts where the schools kind of do their own thing, that really required us to be more flexible and work to identify campus level champions. So the more support that the school nurse or campus level champion had from the school leadership and other staff, again, this sort of mirrors the district level champion, the more successful that their particular vaccination clinic was. And then our team would step in to provide consistency and continuity for the campus level partners from year to year. And so one of the things that was really successful for us was engaging with different types of engagers, right? So there are folks at the campus level who have access to parents, they work with the community, they know their community, the culture, the families, and they have trusted relationships with the parents. And those folks have really made excellent school level champions in working directly with our implementation coordinators. Um, and kind of going back to the district level support, having a coordinator at the district level, we have found can be a really excellent asset to assist the nurses in our participating schools, and in some cases step in where a school may not have a school nurse, which I know is still surprising to some people. But in some districts, it's up to the principal whether to hire a school nurse or not, and provide funds. And so not all of the schools have nurses. So having a coordinator at the district level can really improve the success of the program and enable access to immunization records where needed, for example. And encouraging nurses to routinely enter all vaccines in the student immunization record rather than only the ones required by the Texas Education Agency for school attendance was really instrumental to understanding the HPV vaccination rates and identifying opportunities for improvement. But it also really helped the nurses to understand that many times the families are relying on them to provide a complete picture of their child's immunization records, right? So we've been through a lot of different situations in the last several years, floods, pandemics, other natural disasters. Um, Parents move, they lose their records. And so, we have found through this work that many nurses are not entering HPV vaccines typically into the students' immunization record at the school district because it's not a school required vaccine. And that's one of the things we've been reinforcing also through the education. And we're starting to see tremendous improvements in the consistency by which they are entering HPV vaccination, even among students that don't participate in our clinics, but all of their students. And so that training has really been helpful as well. So when we look at the social marketing campaign, this is really where flexibility has been a big overarching theme. Communicating with families in our partner districts is really intrinsic and central to our mission. So what we had done is we originally started working with a marketing agency, and then a couple of years ago, we switched to working with an in-house specialist on our team, who's wonderful, Amy, who's on the call as well. And that has really helped us to be able to more quickly shift gears when needed and sort of be on top of how things are performing so that we can adjust and do better and sort of be very dynamic with our social marketing strategy. And so we have been able to be responsive in developing strategies for our social media posts, both our paid advertisements and our organic posts, that has really been a little bit more relevant to our audience and partners. We did a social media scan and audit as part of our work in the last couple of years, and really created a lot more diversity in our posts. And I mean, like with information and images, and sort of, for example, switching from illustrations to faces and including real people in our campaign imagery. And that has really helped to provide families and the community with information about education and health and family and other topics, in addition to the information about the vaccination clinics. And so we've really been able to tailor our social marketing strategies and creative materials in that way. And we also have expanded our audience in the last several years. And so we started off with middle schools only, but have moved into high schools in select school districts. And so that meant we really needed to retool and re examine our outreach and social marketing approach to reach teens themselves, right? Especially the ones who are of age to consent for their own vaccines at this point, in addition to reaching parents of older teens where the messaging might be slightly different than the messaging for the parents of early middle school or younger teens. Um, and so doing all of that and being flexible and being able to modify our strategies when we needed allowed us to debut new strategies and discontinue activities that weren't performing quite as well. Our healthcare providers have really been instrumental to doing this work, and we've worked with many over the years, um, mostly consistently, meaning that we've had some partners for all 7 years, and then as we've expanded to new communities, we've been able to introduce new mobile clinic partners to the team and to the initiative. And the key really has been to partner with an established and trusted mobile clinic organization, because that buy-in from the community and from the parents is really impacted when they feel, okay, this is an organization that can be trusted. So for example, here in the Houston area, we work closely with Texas Children's Mobile Clinic program, with Memorial Hermann, and with Christus, all which are, really well known and trusted healthcare providers in our community. And so that's something that is really important, to collaborate with an experienced organization that is able to provide vaccines on campus. So not all healthcare providers are geared towards, for that type of activity, for being able to transport vaccines and do the work outside of the traditional brick and mortar clinic. And so, those folks really have a solid reputation in the community and the experience that's needed to conduct pre-consented clinics where the parents don't have to be present if they sign the forms in advance. And at the same time, we recognize that we may not always be able to change constraints, right, that are inherent in a mobile clinic practice. And so we have had to sort of become aware and adjust, with different issues over the years. So, for example, issues related to student eligibility. Many of our mobile clinic partners receive their vaccines from Vaccines for Children program. And so we have been mostly unable to vaccinate students with private insurance, although we have worked with a federally qualified health center that was able for some of the clinics to provide those vaccines for students with private insurance through separate stocks. So there's sort of logistical constraints in place that you need to consider and move around, work around the availability, right? Providers don't only work with All for Them. They have other existing collaborations in the community and commitments. And so being able to work around schedules that work for both the provider and for the school districts, making sure we're not scheduling things like on days that the school isn't in session, or field trips, or working around testing, and then making sure that we're also keeping on top of the consent process for the providers. And so that has been sometimes a challenge, in that every provider has different forms that they use. So making sure that we're being cognizant of that, whether it's paper forms or electronic forms that we're using, and then modifying our materials to make it very clear to the parents, what all is involved and what's needed to complete the forms. And then one of the really exciting things for us has been recognizing that this really has become a reciprocal relationship and not just all for them taking and saying, we need you guys to come out and do vaccines. Um, but the providers have let us know that they've also benefited from their partnerships with our team. And so some providers have been able to raise additional funding to hire more staff and increase their general capacity, not just for providing our clinics, and then also increasing their own rates of compliance and entering vaccines into MTRAC. One of the providers has let us know recently that through their work with us, they've actually been able to reach the ideal 2-to-1 HPV to Tdap vaccination ratio in their general patient population. And that has been super exciting and sort of a gift for us to realize that it's not just what we need, right? And that this is really benefiting the community, the schools, and the providers that we're working with. So when we look at community presence, we have really learned that the personal, although we have this social marketing campaign that we're very proud of, right, which is a little bit more passive in some ways, the personal interactions that we have really make parents feel safe and heard, and are truly an excellent return on investment for the clinic participation for the amount of time that it takes our staff to do that engagement. And it also really helps to build trust and visibility in the school district and in the communities, especially the ones that we've been in, for example, for 4 to 7 years now. Um, and so we have realized there's truly tremendous value in approaching our community outreach tactics with that flexibility. So for example, contacting parents of students who needed immunizations to let them know about our clinics, and this was done in partnership always with the schools. Talking to parents as they are waiting to pick their kids up from school and they're just sort of sitting there in the carpool line, and it gives them a chance to ask questions and get answers from a real life person who's there representing our project. Um, and during those engagements, we've really been able to leverage that time to educate families about HPV and about the vaccine. We've created interactive games and other types of meaningful engagements at some of the events that we've attended. So, open houses and parent nights and catch family nights. So, we really have tried to take advantage of as many community facing events as possible to answer questions for parents and even help them fill out consent forms right there on the spot to alleviate that extra burden from them having to do it at home. And so those relationship building moments that we've been able to have really allow us to foster more buy-in from the parents and from the community. And then when we think about sort of crisis management, right? The pandemic really has had lasting impacts on our mission, and it has offered both challenges and opportunities. And so during the first year of the COVID pandemic, you all, I'm sure, remember that schools were basically closed in many cases, especially in the very beginning as students were doing virtual learning. And in many cases, the schools just did not allow outside visitors. And that was actually the first year of our expansion grant. And so we really had to be flexible and adaptable and sort of switch our tactics a little bit to be able to still offer all for them at its core, right? At its foundation and what our mission is, but then being flexible to the school needs and the provider needs. And so we worked with our provider partners at that time to create drive-through clinics. And although parents did have to be present, it allowed us to follow COVID protection protocols while still enabling the children to get the vaccines that they needed. And at that time, we actually switched. In our first grant, we were providing 5 adolescent vaccines. And at the beginning of the pandemic, we realized that with all of the missed opportunities and parents and youth not going to the doctor, avoiding clinics, um, during the height of COVID, students were behind on all of their immunizations, right? Not just HPV vaccination. And so It gave us the opportunity to work with our providers to expand our offerings to all childhood and adolescent vaccines, and that's our approach from that point forward. And we have also been able to get siblings and multiple family members vaccinated at some of our larger district-wide events, which were also created in response to the situation. The one vaccine that we elected not to offer at our clinics was the COVID-19 vaccine when it became available. And we made that decision in partnership with our healthcare providers and with the schools. We found that because that vaccine was so new and there were so many questions around it, um, what we did not want to do was then add or introduce hesitancy for the routine immunizations if they were given at the same time as the COVID vaccine. And we actually had lots of parents call us and say, well, are you guys offering COVID vaccine? Because if you are, then I don't want to do it. And so when we let them know, we're doing routine childhood and adolescent vaccines, that actually alleviated some of the concerns. But we did make it clear to parents in our conversations and in the written materials that went home that if they did want the COVID vaccine for their youth, for their children, that we would help them find out where to get it. And we did that in those cases. But this was something that we had to sort of think about what would be the best approach for all for them, and in still allowing opportunities for parents to get their child vaccinated against COVID with more of a referral system. And so again, I'm sort of going to end this lessons learned section with flexibility is key in all aspects of the project. And that's something that we have really truly learned from day one, which was right when Harvey hit. Even before we knew we had to be flexible, we had to be flexible. And so this has really been an interesting past 7 years, and we continue to learn all the time. You're right. Like as soon as we think we have it down and we're good, something changes at the school district. The champion leaves, and we have to engage with a new person. And so there's sort of this rolling flexibility on the implementation piece. But it's been a very exciting journey so far. So I'm gonna switch tactics just a little bit, or topic, excuse me, and sort of talk about what's next. So as we move into the future of the All for Them program and our approach, we're starting to focus our efforts on getting All for Them into the hands of those who can implement it. And so last March, about a year ago, we received a dissemination grant from CPRIT to develop and pilot test a multifaceted implementation strategy for schools, school districts, and healthcare providers to use in their communities so that those communities can use All for Them and implement it independently of our team. And so we're using implementation mapping, which is a systematic, multi-step approach to developing implementation strategies to improve the adoption, implementation, and maintenance of evidence-based interventions in real-world settings. And we're still working on the strategy development piece actively right now with our team, and we anticipate that the dissemination strategies will include an implementation guide and toolkit, sort of step by step to help folks implement this in this strategy, the All for Them strategy. And it will include a training and technical assistance program as well, including Project Echo style sessions to aid users as they undergo the implementation process. We're also planning to build a learning collaborative as part of that technical assistance so that users can engage with and learn from each other as they go through the implementation process. So we are currently in the process of recruiting schools and districts and healthcare providers to participate in the pilot implementation project. If anybody is interested, we're happy to share the information to connect with our team and set up a meeting. So we're sort of doing the initial stages and engaging with FQHCs and community health centers, small, large school districts. We're really open for anyone who has the appropriate setting to lead and implement all for them, to participate in the pilot and help us learn whether the strategy that we're developing is useful for schools and healthcare providers to implement all for them, and how we might improve it in future iterations. And I will turn it back over to Paula. Thank you.
Thanks, Efrat. Before we end, we'd want to acknowledge our collaborators and supporting institutions. Including many of those folks who have served on our All for Them advisory board. These folks have been integral to the planning and implementation of the All for Them initiative, and we couldn't do it without them. So we're so grateful. We're also incredibly grateful to CPRIT for generously funding this work for the past 7 years. And we're really excited as we begin another 4 years of implementation with our project partners on our newly funded maintenance expansion grant. And finally, I want to thank our amazing team who have all worked so incredibly hard to make All for Them successful. So none of the work that we do would be possible without these amazing folks. And I owe everything to them. So grateful to the team. So we wanted to stop there and see if anybody had any questions.
And Eric McKinney, I can put the last slide up in just a moment. If I don't know if you all are opening it up for questions or not.
Yeah, if anyone has any questions, I think looks like Mona Lisa has a question. Let me see if I can. Yeah, Mona Lisa, you should be able to talk now if you want to ask your question.
Wonderful presentation, and I had an opportunity to listen to this before as well. And I'm trying to do something of a very, very small scale, but this is very informative for me because I'm still in the designing stage. So here I'm looking at more at the ethnic organizations and parental education on HPV vaccination. So one of the challenges which I encounter is the mistrust associated with how the data is going to be used. Did you encounter anything like that since you had served many of the underserved community, and how did you address that? And how did you I understand the immunization record, you got it from the clinic, obviously, but for me, I don't have any clinic work directly. But how do you get some level of confirmation from the parents, or how do you convince them that data is safe with us, or this is something you can show to confirm the immunization after the post-test or pre-test information?
Efrat, do you want to do that?
I'm happy to tackle that. Thanks, Mona Lisa, for your question. We do obtain written consent as part. So for the students that are participating in our clinics, obviously the healthcare provider partner is the one that's doing the vaccines, and so they collect that data and put it into their EMR. That's all sort of obvious from the perspective of the parents. But then for our project to know the vaccines that are given as part of the consent forms, we do have an IRB approved stamped consent form, and it does look a little bit daunting because we're also under the restrictions of our IRB, so we have to include that this is part of research, even though this isn't actually a research project, and so it can look a little bit overwhelming. We do sometimes have parents that don't want to sign that form, and that's okay. And in that case, we don't collect the child's individual information, but most of the time when they're not sure, we just let them know, we're the ones organizing this clinic and this is part of the project, and it really helps us to just understand the vaccines that are given. But an additional benefit that we have, which you may consider in some way, is that signing the consent form also, and it specifies this on there and we explain it, it allows us to share the vaccines that the child is getting with the school nurse so that the district can update the records, and that way the parents don't have to then, after they get the vaccines, go back themselves to the school and provide that. So the parents actually see it as a benefit in many cases that we're collecting the data, because it allows us to, that specific form also allows us to share the information with the school, and they're like, okay, great, now I don't have to send the school nurse a record. And so I think us collecting the data actually is a benefit to the parents in that case, and that has really alleviated it. But every once in a while, the parents don't want to sign it, and that's okay. And then we just get sort of total numbers of vaccines given, and that child's information is not part of our database. I don't know, Paula, if you want to add anything to that.
No, I think that was the key, is that, the IRB provided or helped us to craft language that, although it's a little scary, it was the best we could do to ensure that the parents understood the purpose of our data collection.
Yeah. And I see that Amy Pine has a question, and I saw Karen Schwind raise her hand at some point too. I don't see if it's raised now because we can't see the participants, but I don't know. Eric, if it's okay with you, we can go ahead and answer Amy's question. Do you want to tackle? Okay, so for those who can't see the chat, thanks Amy Pine for your question. But the question was, how do we handle second dose events, right? Because HPV is a multi-dose series. And so with our youth who are getting their first vaccine at our clinics, we provide a reminder card with their vaccination record that goes home to parents and lets them know exactly when they're due for their next dose. In many cases, they do come back when we're there either the following semester. We usually do about typically one clinic per school year per school, because we're in dozens and dozens of schools, and so it's difficult to go back to all of them multiple times. Every once in a while we can, or we can encourage them to come back to one of our district level events within the time frame. So many times they'll come back to us at a subsequent clinic, but we do provide them with a reminder card and our phone number so that they can call us for, figure out how to get to one of our clinics or another clinic, or recommend that they go back to their primary care provider if they have to. And so that's sort of our bridge to try to connect them. I will tell you personally, many times at our clinics, I see kids coming back the following academic year with their forms. We provide everything in a branded envelope with the student's name, and they come back and they're like, I have my reminder card. Like, I know I need my second dose. And we also do targeted outreach to the students that we know still need second doses. If they got a first dose with us the year before, if they're still in the schools, they get a specific letter home to parents saying, hey, remember, you got your first vaccine with us. It's time for your child's next dose. Fill out the forms. And that has really helped to increase completion as well.